Hello, everyone. I'm Hanovi Schoonover of Red Wing Consulting, the host of this event, and I'd like to welcome you to the webinar. Before we begin, for those who may not know, Redmond is a nonprofit organization that provides tribal technical assistance on a variety of programs, including but not limited to housing and homeless services, children and youth, and elder abuse. This ranges from policy review via email to site visits. If you're interested, you can contact me at hanovi@red-wind.net. That's HONOVI at red-wind.net. As the states, this project is supported by grant number 15 JOVW 21 GK 02258 TRIB, which is awarded by the Office of Violence Against Women, U.S. Department of Justice. The opinions, findings, conclusions, and recommendations expressed in this presentation are those of the authors and do not necessarily represent the official position or policies of the U.S. Department of Justice. This webinar is a part of our Tribal College Campus project, and presenting with us today is Tammy Scarlet. Tammy Scarlet serves as a forensic nursing specialist, providing training and technical assistance. Tammy has been working as a registered nurse since 2010 and received her master's in public health with a concentration in global health in 2020. Tammy started working as a full-time forensic nurse in Colorado Springs, Colorado in 2016. A few years later, she was a principal investigator on 2 research projects involving non-fatal strangulation and HIV NPAP adherence and barriers. Currently, she holds her certification in sexual assault nurse examiner adolescent/adult, which is SANE, and sexual assault nurse examiner pediatric, SANE-P. This event does have captioning, and it should automatically be enabled on your screen. If you have any questions or comments, you can put them into the chat box or click the little hand icon. I'll now turn them over to Tammy.
Hi, everyone. Thank you again for being here today. And like Hanovi mentioned earlier, my name is Tammy Scarlet. I'm a forensic nurse. I work for the International Association of Forensic Nurses right now, where I work on the ISAAC project, which is the Indigenous Sexual Assault and Abuse Clearinghouse project, funded through OVW, or Office on Violence Against Women. The project helps provide technical assistance and training to anyone who responds to sexual assault in Alaska Native and American Indian populations. So that's kind of what brings me here today to help talk about this topic. Slide. Just as a quick disclosure, the planners, presenters, and content reviewers of this course disclose no conflicts of interest. And the International Association of Forensic Nurses is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. Bye. So today we're going to talk about tribal colleges and universities and sexual assault nurses. So we're going to kind of discuss the learning outcomes, which will be understanding the role of the sexual assault nurse examiner, then discuss the role of a sexual assault nurse examiner in response to sexual assault, and understand other considerations for establishing a response to sexual assault in tribal colleges and universities. Next slide. Now for me, I like to discuss a flow of kind of what we're going to be talking about today. So today we're going to say, what is the problem? What is a forensic nurse examiner? What is a sexual assault nurse examiner? How do you become a SANE? The benefits of a SANE and a forensic nurse examiner. What is the medical forensic exam? What's the response to sexual assault on campus? And then how to partner with a local sexual assault nurse examiner program or SANE. So that kind of just helps to kind of understand what we're going to be talking about in a good flow. So let's kind of get started into that then. We'll go to the next slide. Now, we wouldn't all be here if we weren't concerned in wanting to respond to violence, especially sexual assault that happens on our campuses. We want to be able to find a good approach to that response to sexual assault. But first, it's good to know what exactly is even happening. So according to RAIN, 13% of students experience rape or sexual assault in the form of physical force, violence, or incapacitation in graduate and undergraduate levels. We can see the breakdown here as a significantly higher number in undergraduate students especially. Not only this, but since entering into college, 5.8% of students have experienced stalking. And we know that during the first and second semesters at college, these students have an increased risk of sexual violence. Next slide. Now we know that violence is happening, but do we know about this in regard to reporting? What do we know? So according to Know Your 9, 12% of college students who have experienced sexual assault will report this event to authorities. While of those who've also experienced a sexual assault while incapacitated, such as a drug-facilitated sexual assault, only 7% reported to law enforcement. If we think about the population of students we have in our universities or colleges, that kind of really puts us into perspective. And then one other statistic to consider is that only 2 to 10% are false reports. Now, this is consistent with all other reports of crimes and their false reporting too. So what we want to keep in the back of our minds is that this can come up in conversations, and we need to be able to know how to address it and understand that this is a serious problem that we want to make sure we are understanding and responding to appropriately. So overall, we see a high number of sexual assaults, and these are happening on our campuses, and we need to be able to know how to combat this. Next slide. Now we find ourselves sometimes asking, well, why aren't these students reporting? With high rates of violence and so many of our students being affected, why are we only seeing 12% report overall and only 7% who were assaulted while incapacitated reporting? Well, according again to Know Your 9, not wanting others to know, lack of proof, fear of retaliation, being unsure of whether what happened even constitutes as an assault. Some say they didn't even know how to report, and others fear that they will be treated poorly by the criminal justice system. These are all hindrances in the process for reporting and need to be acknowledged as real barriers that we have to address again. I myself, when I was in college, had no idea how to report, and I can imagine having all these same feelings. So despite being a nursing student, I still didn't know where to go, who to report to, how to get there, or even what the purpose was. And even now I know my reporting options, and I would still have some of these fears when I presented after a sexual assault. So I can't dismiss them so easily myself. And I know that a lot of our students might feel this way. Next slide. Now, when we think of sexual assault, we think of violence or, violation, yet we don't always make the connection that there are many health aspects associated with this violence, let alone sexual violence in general. In particular, there are many psychological, emotional, and physical health consequences of sexual violence. Now, along with pregnancy, sexually transmitted infections, pain and injury that can be experienced by survivors, we know that 34% of college students experienced post-traumatic stress disorder. 33% reported experiencing depression, and 40% reported substance use. These are all things that can have those lasting effects and are hard for someone to seek treatment for, leading to possible isolation, further health consequences, and in our populations, the possibility of not being able to continue their education. So there's a lot of health considerations that we need to understand. Next slide. And not only do we see the health consequences, but there are others we might not consider, such as economic. I know I don't always consider that at first too, but there are a limited number of studies about student survivors and the specific cost estimates after violent episodes. And there's an estimation by the White House of between $87,000 and $247,000 per rape. This can be seen in the form of medical treatment, counseling, other areas associated with schooling, such as tutoring, lost tuition, trying to make up for that last time by adding on time at school. Like we talked about, some people might not even be able to finish school. And these are, again, things I don't always consider, and other, factors that we might not see as a hurdle, but someone else might see as a hurdle. So we set our students up for failure on more than one level when we don't address the healthcare, psychological, and financial needs from the beginning. Some of these students might have to drop out, like we said, because of a burden, or it might make it difficult for them to even just move on from an assault in general. Next slide. Now, again, we ask ourselves, what can we do about this? We can't prevent violence and stop it in its tracks today, even though I wish we could, but we can make sure we think of ways that we can tackle the healthcare needs of these students. And economic, psychological, all those things we literally just mentioned are things we can try to address today. Now, one of these interventions is seen in the care of a forensic nurse. A forensic nurse is a registered or advanced practice nurse that has received specific training and education within their field in an above and beyond capacity with basic nursing education. So forensic nurses can work in a variety of fields, such as a sexual assault nurse examiner. They can work with intimate partner violence, child and elder abuse or neglect, death investigation, even in corrections and the aftermath of mass disasters, among many others. Now, there are many locations that these forensic nurses work out of as well, such as correction institutes, psychiatric hospitals, medical examiners' offices, hospitals, community anti-violence programs, local clinics, child advocacy centers, and more. So all this to say, this specialized training makes them well suited to be a key person when a student reports sexual assault due to their compassion, expertise, and specialized focused care. Next slide. As discussed in the previous slide, sexual assault nurse examiners are a type of forensic nursing. My way of viewing it is that forensic nursing is the overall specialty where different kinds of specialties like fall underneath those subgroups, such as a sexual assault nurse examiner. So a sexual assault nurse examiner is a registered nurse who's completed that specialized education along with clinical preparation to care for patients who have experienced sexual assault and or abuse. So a sexual assault forensic examiner, or a SAFE, is a healthcare provider other than a nurse who has taken the training in clinical preparation, such as a physician or physician's assistant. For the purpose of this presentation, I'm going to talk about SANE instead of going back and forth between forensic nurse and SAFEs and SANEs. It's just easier to kind of address it that way. But what we do know is, again, that they're specially trained to see these patients and these students. Next slide. In order to discuss the expertise of a SANE, we need to discuss the process of becoming one, kind of help us understand. We have it detailed here. I know it's kind of difficult to see. It was kind of hard to fit it into that slide, but I'm going to walk us through it. So starting at the top, you start out as a registered nurse. You get to know the local requirements for your practice and you practice like at the bedside, wherever that is. Then you take a didactic SANE course. This could be adult, adolescent, or pediatric. So didactic is kind of hearing everything that happens, doing that verbal training, either, like I said, in person, it can be online, so you learn the content. After this, you find a place to complete a clinical preceptorship. That's where you learn hands-on training. So you learn to do an assessment, you learn how to collect evidence and all that. This allows the nurse to practice as a SANE. So once you complete that didactic and clinical training, you can then become a SANE. There might be more requirements in your area, but we just make sure to keep the basics and follow those with your nursing board. So after meeting these specific requirements and after practicing for a while as a SANE, you can take a SANE A, which is a sexual assault nurse examiner adult and adolescent certification, or a SANE P, which is a sexual assault nurse examiner pediatric certification. That's where I'm saying, hey, I'm an expert and I'm certified and I've gone above and beyond to be an expert in my field. I've taken a specific test and it says that I know this content very well. So I'm able to speak to that a little bit better. We also have continuing education opportunities to help keep up proficiency as well. So it's an ongoing practice as well. Next slide. One of the things I also like to kind of talk about is to walk you through my process, and it'll kind of come to play in here. So in order to understand the expertise of a SANE, we need to discuss the process of becoming one, like I said. So I started out as a bedside nurse. I worked in the emergency department. Then I got my SANE training, where I worked at an on-call program where I worked as an emergency nurse and then came in when there was a sexual assault when I signed up for call. After that, I was able to go to work at a full-time forensic nurse program. Then I sat for my certification for adult and adolescent, and then for my pediatric. Then, of course, brought me to where I am today, working at the International Association of Forensic Nursing. All that to say, there's a lot of different pathways that can happen, but there's those typical steps that you follow. With the SANE, just the SANE, like sexual assault nurse examiner, I was only seeing sexual assault patients. In my forensic nursing role at the hospital that I recently work at, I see all kinds of patients. So let's kind of talk about that and understanding all aspects of violence. So as I mentioned, I worked in an on-call program where we only had the capacity to see the sexual assault patients. So as a forensic nurse moving on, we see all victims of violence, but we know that there's that overlap. So as a forensic nurse, I see sexual assault, I see elder abuse, human trafficking, at-risk adults, all of that. But we know that violence doesn't happen in a vacuum. We know that sexual assault might present with stalking or with an element of intimate partner violence. So we need to understand that as a SANE, we're also trained in understanding other aspects we might see, especially within the student realm of dating violence, stalking, intimate partner violence, human trafficking, and drug facilitated sexual assault. And we'll talk a little bit more about this in a little while too. Next slide. Now, there are many benefits of having a SANE or F&E provide the care to your patients. I know I'm biased, but I can offer some really good recommendations and understanding into it. So such as providing comprehensive medical care and responding to patients' psychological distress is essential for long-term and emotional well-being. So early intervention is particularly important with sexual assault patients because most don't seek follow-up care. And with that, some studies suggest that SANEs can have a beneficial impact on patients' psychological health. Now, we know that knowledge, skill, and training, as discussed before, to address this type of violence in a unique way can have a huge benefit on our patients and or students on the campus. Next slide. Now, a study by Eisenberg et al. Wanted to look at the association between reports made to legal authorities by college-age women who experienced sexual assault and the connection between their emotional well-being. They received data on 2,162 women who were college students, where they analyzed associations between reporting sexual assault to formal versus informal resources, and then to understand that diagnosis with depression, anxiety attacks, anxiety, and PTSD, along with self-rated health. Now, they found that these 4 diagnoses were found with what they stated as significantly higher rates for those who reported to formal sources, like healthcare or law enforcement, compared to reporting to only friends and family. But no differences were seen in self-rated physical or mental health, according to the study results. So in the article, they state, where possible, post-assault supportive services on campus should include sexual assault nurse examiners, advocates, and mental health service providers, as they are trained in trauma-informed care from short to long-term care. This includes training on historical trauma or even previous traumatic events. They eventually state that peer advocates or residence assistants can support those who have experienced sexual assaults with the support offered by forensic nurses to these peers and provide direct services. Again, overall, there can be benefits to having a forensic nurse or SANE on campus. Next slide. As mentioned in the previous slide, forensic nurses are specially trained to understand the nuances of trauma and how we see it in our patients. Not only do we see the one-time event of the traumatic assault that brings them to us, but we can also see other things such as childhood trauma or historical trauma that can cause long-term emotional, psychological, and even physical distress and consequences where special care is needed to not only provide that trauma-informed care and a patient-focused approach, but to allow acknowledgement and then a plan of care to be discussed within with the patient and with their input. So trauma-informed care is born out of an assumption that every person seeking services is a trauma survivor who designs his or her own path to healing, facilitated by support and mentoring from the service provider. And that's according to Stanford School of Medicine. So according to Stanford School of Medicine, again, we understand that where the patient's at is where we need to meet them. And I teach a lot saying that if there's a patient who presents intoxicated or is so tired because they haven't slept because it's just been bothering them, can we take a quick nap? Can they have a friend present? Maybe they don't even need evidence collection. Maybe that's not their way to process and not what they need. This is all their choice. This is something that we discuss the risk and benefits with. We want to make sure we give that informed consent. But overall, we're doing what's in the best interest of the patient and definitely not what is my agenda and what I think would be best. We also recognize that historical trauma can have an impact on the current assault, either leading to certain traumatic responses in the moment or leading to further compounding trauma from this assault as well. Acknowledging that there's more to this person than this one event, that there may be things in the past that we have accumulated, such as that generational trauma or my own cumulative trauma, will help lead to better outcomes for our patient. Of course, the patient-centered and trauma-informed approach will encompass all the considerations that we're going to talk about later on through the slides. But it's just helpful to know that that's a big part of our practice. Next slide. Now, when we talk about providing the best approach for a patient encounter for students who present after sexual assault, we want to talk about the sexual assault medical forensic exam. As a sexual assault nurse, we can provide a specialized exam that basically sounds like the name. It addresses the healthcare needs of the patient through the medical aspect, while also collecting evidence, if indicated and appropriate, for possible use in the criminal justice system. So let's break down a sexual assault medical forensic exam and the importance of what can be offered. I'll probably refer to anyone seeking medical forensic exam as a patient. It's very normal for me to say that. So just know that student or patient might be used interchangeably. That's just, habit to say that. Next slide. Now this slide has a lot on it, so don't be overwhelmed. We're not going to go over this too much, but this is from the National Protocol for Sexual Assault Medical Forensic Examination, Adult and Adolescent. This is the second edition put out by the U.S. Department of Justice. So we'll kind of talk about all this in detail in a little bit. We'll cover all of these things. But as you can see, there's a lot involved in it, just like in small bullet points, let alone what we're going to talk about. So I can't even imagine having someone do this who is not trained in the exam, or someone like an emergency room nurse where we send our patient and they don't understand how to do all of this. That could be a disservice to our patient. So for example, one of my longest exams was 8 hours. And sometimes I'll follow my patients over days if they're admitted to the hospital. So there's things we can do to help treat our patients and understand the intricacies of what we can and can't do. But these are high standards that need to be met in its entirety if we can. And we need to be able to make sure that if we are offering this, or if we want to think about offering this, we need to meet these high standards. All right, next slide. Now, part of the high standard is allowing the student to participate in their plan of care and to consent to what they wish to in the exam. Like I discussed earlier in the trauma-informed part, there are some variations for each program or team or practitioner in the resources or capabilities that they can offer. We'll talk about those and see how those guide the treatment provided. But let's look at the process of the medical forensic exam in more detail. We're going to break it down a little differently than the slide we just saw before. But I want to start out by saying that, of course, these are all the best laid plans. This is a view that's streamlined, the one that I'm going to show you, but it might always be like this. And that's why we hope for the best plan, but plan for scenarios that might not be possible, especially within a capacity of a campus or university. All right, next slide. We're going to talk about the medical forensic exam because it helps us understand what kind of response we would need to mount within a university or campus. So understanding the intricacies and the foundation of why we do what we do will help us understand how we build that even bigger or bring in resources or contract out for resources. So here we see in this first slide, a few aspects of the exam broken down. We're going to break it down in the next couple slides as well. So with initial presentation after an assault, regardless of how far out it's been, it's important to make sure medical screening is provided. So we're ruling out any immediate medical concerns that need to be addressed. I kind of see it as getting looked over sometimes if the patient presents for sexual assault or domestic violence. I find people tend to see this as an emotional pain and forget that there can be significant medical consequences from assault. So we want to make sure there are no immediate medical concerns, such as significant vaginal bleeding, complications from strangulation, or other internal external injuries. So whether this is completed by a provider at your facility or by the sexual assault nurse examiner, we want this done. We also want to address that the consent piece. As a medical forensic exam, this is not an emergent, immediate life-saving piece of the medical puzzle. Now, some of these things are extremely important that we have to do, but aside from that, we have to understand that emergent medical piece might need to be addressed first. So we want to know that also we're giving choices to our patients. And sometimes we want to know what they need and what they want from us. So we obtain a medical, surgical, gynecological history to make sure we're providing appropriate care based on their currently existing conditions that might interact with some medications or cause predisposition for discomfort during the exam, or scars or findings that might even mimic injury that we'll need to know of ahead of time. Next, a psychosocial is important. This is where we gather information about the patient, their life, their support, their resources, and then a history of the event to guide the findings. So this will help kind of provide diagnosis and treatment. A history of the event can be obtained through summarization of the assault, or it can be a way of capturing it word for word in quotes of what the patient says. This is, of course, very different from law enforcement interview, where they ask a lot of different details and they have a different purpose for theirs. But for ours, it's to help understand how to treat and diagnose our patient. Again, nursing is medical first. We want to be nurses first and help our patients first. The other stuff is kind of bonus and awesome, but we want to make sure we're coming through that view. All right, next slide. Okay, part of that treatment is medical intervention of sexually transmitted infection prevention and or care, pregnancy prevention and or care. We have other things that we can kind of address, such as HIV or human immunodeficiency virus, or hepatitis B prevention, tetanus, or pain medication. So these are things that, we don't necessarily always ask about unless we know what happened during the assault. So we want to make sure we are getting the information we need in order to ask these questions. We'll do what's pertinent based on the history and other questions that we will, glean information from. So according to Sachs, Ladd, and Thomas in 2021, they say that the transmission of sexually transmitted infections after sexual assault varies widely among populations. They range from high reported rates of 12% for trichomoniasis and 19% for bacterial vaginosis, to lower estimates for chlamydia 2% and gonorrhea 4%. And we know that some of these might be pre-existing, but we can even still address them at the time of the exam. We can also address pregnancy-related concerns that would arise as a result of this health outcome. And this is where education and informed consent comes in as well. So for some of these options, there are specific timeframes for prophylaxis. For example, HIV NPEP, or non-occupational post-exposure prophylaxis, it's a mouthful, is provided to prevent the patient from acquiring HIV after a sexual assault. And this is usually only provided up to 72 hours after assault. Therefore, it's imperative that we address these patients in a timely manner. Something that a SANE is trained to provide and to provide education on. So there are lots of other medications, vaccinations that are considered, and we want to make sure that we have the appropriate algorithm or risk assessment based on the event of the assaults. Next slide. After considering which medications might be necessary, we can also determine what we might expect to be completed for the physical examination portion. We can complete a full body assessment and a detailed anogenital assessment depending on where the patient discloses the assault occurred. Now, the full body assessment is looking at all body systems. So making sure there's no skin injury, no difficulty with movement, no aspiration after strangulation that would lead to difficulty breathing. And then a detailed anogenital exam would allow the provider to assess the anus and or genitalia after the assault. Now, while we are doing this, we can do photo documentation of any body surface injury. And with the anogenital portion, we do photo documentation with or without injury for many reasons, such as having another trained sexual assault examiner go behind and make sure there's nothing we missed, nothing not noted on the exam. We look at this in a quality assurance process, or this can be used for education for new SANEs, for ongoing education, and even for evidence in a potential court hearing. So evidence collection can be completed as well, if indicated, which is guided by the history portion of the exam. Evidence collection timeframes might be different and vary from state to state or jurisdiction to jurisdiction. For example, my local jurisdiction has taken recommendations from the national protocol, and local guidance in our timeframe for evidence collection is 120 hours. Overall, evidence collection must be done appropriately and chain of custody maintained, which I always say is if it's not done right, then we've really done a disservice to our patient after all that time through the exam. So here you can see a sexual assault evidence collection kit for the state of Colorado. And that's what we open up. We can have envelopes on the inside that come with swabs, smaller envelopes, different ways to help collect that evidence and document the evidence that was collected. Other states may have other different kinds of variations like boxes or other different kinds of ways to dry your swabs, but overall, it's kind of just a good example. Next slide. Part of the sexual assault medical forensic exam is understanding that violence does not happen in a vacuum, like we discussed earlier. Sexual assault can be associated with many other types of violence, and the need for specialized assessments to address these unique problems is an area that sexual assault nurse examiners are specifically trained in. For example, in my own practice, I find that almost half of my patients are strangled. This is where blood flow in the neck can be blocked by an external force of pressure, which can result in many types of complications, including death. It's a serious part of violence that most people don't really think about to ask, but it is important. So asking questions to find out what occurred, if there are any lingering symptoms or indications for further medical follow-up, which, for example, in my hospital-based program, we'd have them see a provider. So the International Association of Forensic Nurses has a strangulation toolkit that helps walk through this assessment and documentation. Now, something else we talked about earlier was the drug-facilitated sexual assault, which we know alcohol can be a huge facilitator of this, not just drug use or someone slipping something in someone's drink. According to Gorstein and Riviello, numerous studies have shown that drug or alcohol-related sexual assaults on college campuses are more frequent than forcible sexual assaults, making this a reality that we just can't ignore. So testing for specific drugs can be considered in this case, as an assessment for the patient's health in that moment is also important. Or, as mentioned earlier, sometimes it's beneficial for patients to take a nap so they can recover from that drowsiness, confusion, and then start the exam after this, where they're able to make a more informed decision. As far as intimate partner violence, the National Coalition Against Domestic Violence report in 2017 says that 43% of dating college women reported experiencing violence or abusive behavior from their partner. This necessitates the specialty for asking, recognizing, and understanding the implications for safety and resources. We understand that sometimes leaving that intimate relationship might actually be dangerous, and that a safety plan and possibly returning later might be in the best interest of the patient. So intimate partner violence is something we really want to be addressing as well. Human trafficking is also a problem. So where prevention and education are a big role in the sexual assault nurse position. These, of course, are not the only things to watch out for, but they are big examples of additional areas of education and knowledge that are important when addressing sexual assault in general, but especially on a college campus. Next slide. Now, after all is said and done, We can address sexual assault in the moment and do our best for prevention, but so much can go on behind the scenes and after the patient leaves. We want to make sure we are having those connections for proper follow-up with referrals who are aware of the unique needs of this patient population. Also, providing appropriate advocacy response is an integral part of coordinated response to sexual assault. So as a nurse, I'm able to advocate for the safety, health, overall well-being of my patient. But prior to arrival, during the exam, and even after, there are many of the aspects of the process that I just can't be there for. So that's where community-based advocacy, advocates within the college or university setting, or even sometimes law enforcement advocacy is a benefit that they can provide. A big part of my last role in my hospital-based program was working with community partners as well as providing follow-up calls to make sure our patients were getting the appropriate resources and care. This can be a big undertaking, as it's just not the initial visit that's important, but the whole spectrum of care. So understanding that if our patient was prescribed medications and we call them a few days later to see if they're even taking them, to make sure that they got all the resources they need for a follow-up, to make sure that they're getting labs drawn after those meds, or that they're getting further follow-up testing, or that they're even tolerating the meds well. Those are important parts that advocacy can help with, appropriate referrals, like I mentioned. So it's important to understand that continuation of care. Next slide. Of course, I'm a nurse first, but I work under the expectation that this patient encounter might go to court. So knowing the ins and outs of the proper chain of custody, testimony, and being able to discuss what findings and evidence was collected during the exam is important. Having someone who is able to speak to this in confidence will help with better outcomes and offender accountability. We don't work to only prove the suspect wrong or the victim right. We want to work towards the truth and upholding the judicial process. A sexual assault nurse examiner provides that testimony training and upkeep on how to maintain evidence and understand the findings during an exam, only to help strengthen their knowledge base and expertise when they're called to court. We can testify as expert witnesses as opposed to fact witnesses, especially. So as a fact witness, I can speak to, like, let's say, who I saw running away from the scene of the crime or what they were wearing. But as an expert witness, I know more than the average person, and therefore I can speak to my opinion and findings, and which helps bring a lot of education and understanding to the trial. Again, we work to make the health and well-being of our patients better, but we understand that everything we do in that encounter must also be done to the best of our ability due to the possibility of this judicial process. Because again, if we're going to do something, we're going to do it well. All right, next slide. All right, now that we know how much goes into a sexual assault medical forensic exam and the importance and need of these for our students who have been sexually assaulted, we want to look at how we implement a response on campus. Next slide. Wanting to have a response to sexual assault on campus is all well and good, but what does it really mean? So for an effective response, we want to look at staffing, location, education and training, privacy and confidentiality, documentation, multidisciplinary team, reporting options and law enforcement, and then prevention and education resources. We're going to kind of break all these down in the next few slides. Staffing, of course, is important because without someone to be there when the patient presents, not much will be accomplished. But what does staffing have to look like? Well, there are a lot of options to take into consideration. There might not be an end-all be-all answer in these following slides, but figuring out what works best for your community and your school is important. So some options for staffing could be contracting out a sexual assault nurse examiner. So hiring someone to work who might work at a hospital or clinic on their other days, such as like a cross-training kind of a thing too. Or hire a nurse practitioner or registered nurse to work specifically at your location. If you were to choose to have student health clinic staff be the response, then of course an option would be to have a sexual assault nurse examiner come in as a content expert to help create the protocols, guidelines, or educate. Telehealth is also a very viable option. For example, a local program will have a SANE on staff who is available when your nurse receives a patient who has experienced sexual assault. And that telehealth nurse will help through the exam via that virtual platform. This is even helpful in programs who have low patient volume or are getting started and up and running, or even just don't have large enough staff volume. So working with closely with these organizations that you might be contracting out, or these nurses, you can also have a memorandum of understanding with local SANE programs as an option. But basically knowing what your options are is very helpful. And knowing that if we are not having something like this and we do contract out with a hospital or have a memorandum of understanding with the hospital, we need to know what the plan is to transport our patients to the hospital. Is there someone even available at that time? How long of a drive is it? Can they send someone with them, like a friend or loved one? So they seem like kind of easy questions. Like staffing is like a first one, like, yeah, we'll just hire someone. It's an easy, check off. But you need to have someone who's a qualified SANE or someone who's willing to work in the environment that can be challenging. So staff support is important and must be built into the plan as well. So staff, of course, is a big first step. Next slide. After considering staffing, we want to say, where do we even put that staff? Is this something where we want to work out of an already existing set of facility, such as a student health center? Or is there a need for use of a different part of a campus? Jennifer Markowitz is a forensic nursing specialist who did a presentation on building SANE programs on college campuses, challenges and opportunities. She stated in that presentation that they were trying to set up a program once in a university where they had to consider where areas students consider to associate with past trauma. So those students wouldn't go to that area. So they had to get buy-in from students and staff of now, where do we go that's safe for these patients to go? So she does a great webinar on this. I'll have it in a resource list or something later if you want that, but it's at the International Association of Forensic Nurses, but it's another really good resource. And another thing you want to consider is if a student presents, is it obvious they're going to go see a SANE? Will everyone assume that they were assaulted because anybody walking in that door will be going to go see the sexual assault nurse? Or are there other resources in that same building that won't necessarily make it obvious someone's going there to receive a medical forensic exam? Or in a place that someone else cannot hear what's being discussed or what evaluation is going on. For example, in a clinic where there are only curtained rooms, or there's only one room, because this could put a lot of pressure on staff to move the exam along as well, so that we make sure we don't take up that space for extended period of time. Sometimes exams don't just take 30 minutes. Sometimes it's a couple hours worth of a process. And it's something that, can't always be rushed, and we want to make sure we do it right. Another thing to consider is sometimes we want to offer showers. Some of our patients really need to shower after an assault. It's like that healthy cleansing just in general too. So sometimes, we want to have access to those showers. Another thing is, what time is the facility open? And when the students have access to it at all times, because we know that assaults don't happen just during business hours. Also, after collecting evidence, do we have the capacity to lock up evidence until law enforcement arrives so we can hand that over to them? It's very important for maintaining the chain of custody, and it's something that we spent a lot of time obtaining too, so we don't want to ruin that. We want to make sure that we meet all efforts to also understand developmentally, culturally, and linguistically appropriate care, which I know you are all very well aware of, but sometimes things that we just don't want to get lost in the whole process because we're trying to understand a whole new process on top of it. Next slide. Now, having a trained professional to complete the medical forensic exam is highly recommended. As all these things previously discussed are so intricate and specialized, it's important to have someone who is trained to treat these patients specifically. Now, remember back to my path to becoming a SANE. If you choose to hire on SANEs, or if you choose to train your staff, we want to consider the training required and allow time for that. We want to make sure they're able to attend that didactic training, either in person or online. Then after this, they can attend a clinical skills training where they can learn to do assessments and gain that knowledge for addressing sexual assault concerns. Skills labs are actually really helpful in that unique training setting where small groups come together and they talk about skills and they run through scenarios. So it's really helpful. Some programs have scholarships to help allow for this. So it just depends on what you find to help support that. Along with patient care, we want to ensure continuing education as well as school and state specific knowledge. Those are kind of tough. And as a forensic nurse who worked at a hospital, didn't always know those or consider those, but those are very unique and specific in themselves. As campuses are unique settings to train patients, we want to know that the nurses are familiarized and comfortable with. And again, I cannot stress the importance of keeping up on continuing education and literature in this field. This field is still kind of new and is still growing. And so it's something that we want to make sure we're up to date on everything and that we're contributing to understanding the importance of new practices for our patients. Next slide. So I'm very much a person who loves a good policy and procedure or a good guideline to follow. So something that I can point to and say, here it is, this is what we need to do today. Well, for a lot of forensic nursing, that can be complicated as not every patient presents the same and there are many gray areas. But with the parts that we can have policies or procedures for, this is very important for establishing a strong foundation. We want to make sure that our SANEs or SAFEs or even our telesafe, that telehealth connection I spoke about earlier, have good standards for their practice, such as knowledge of laws, regulations, evidence-based literature. So this extends to the medical forensic exam and the care provided to the patient, such as, do you have standing orders, or who do you receive your orders for medication, or even your transfer requirements from? For example, what if a sexual assault patient comes in to see a sexual assault nurse examiner and they were strangled and are having difficulty breathing? This needs to be medically addressed prior to the exam. So do we call an ambulance? Do we follow up on the patient after? What do we do if they don't have symptoms, but were strangled? Then ordering imaging, medically clearing this patient. That's now out of the scope of practice for a nurse. So many questions that we need a policy for, hopefully before it comes up. Advocacy services are important to have involved in the response, as discussed earlier, but what does that look like? Do you have them on campus? Do you have them called at the beginning of each exam? What if someone isn't available to come in? Can you do an over the phone conversation? Again, this is helpful to kind of establish a really good relationship with them to understand the nuances of when they're available, where they can be available. Something that I like to also do is understand the process of how things happen and have a collection of those processes. So for example, at our program, we have a binder or we have stuff under our S drive in our computer. So it just kind of says, if you are looking for guidance on this, go to this tab. Or if you need help understanding laws, go to the laws. And it's something that's really good and easy to point to because sometimes when you're stressed or overwhelmed, you can't know everything. And just thinking about all those little nuances to help your nurse or your SAFE just be successful. Another thing is you need to consider that burnout is a real possibility, especially if you only have one or two nurses or providers on. If they're taking call 24/7, that can be taxing. It can also be disheartening when you know that you can't cover all those shifts. And if you can only do 3 and you know you're not able to cover those other 4, you might feel, sad for that not being able to be there and be present at all times, but we know we can't be. So a good way to help your staff out in that way. We have medical storage as well. So medical record storage, access, and release of information. This can be a complication because it's part of our consenting process with the patient to explain where their records will be stored all the way through to testimony and releasing or speaking about that information in court. But we also have to abide by HIPAA and FERPA, which we'll touch on briefly in the next slide. But this is a way bigger conversation, and we could probably have an entire webinar on this topic alone, meaning it's a very important discussion. So looking at other programs, speaking with other content experts would be a good recommendation for establishing these policies and procedures. The national protocol also has a section on developing customized protocols from assessing for needs to distribution and revision as needed. And that reference is at the end of the slide too, end of our slides. Next slide. Privacy and confidentiality is something that needs to be prioritized. Within the medical forensic exam, we do not see a way to separate out the medical aspect from the forensic aspect. As the exam is part of the healthcare response, all of it, but with a forensic component. So when viewing the exam in this way, it's important to remember that there is a need to consider the expectation to privacy within those healthcare records. Whether this is something done at the health center or if the patient is then transferred to a local hospital or clinic, We need to make sure everyone, including those involved in the multidisciplinary team, which we'll talk about in the next slide, are all on the same page. So even having administration, IT, or others involved will help establish a good basis of understanding for your policy on this. Do SANE records become education records if they're used for anything other than treatment, such as release to law enforcement or to the patient? This can be a privacy concern, and Jen Markowitz discusses this in her presentation as well. We want to make sure that we are quite aware of when there's that crossover from it being just healthcare records to then handing it off to a different entity, making it then not healthcare records and education records. And the consequences of this can be simple, just a simple fine line that we can cross. But we want to know that our patients in university or college settings all have the same standards and expectations in mind. Jen Markowitz again pointed out that at one of the institutions they were working at, they noticed the wording that may disclose education records without the student consent if FERPA permits the disclosure. And with this wording, may was an open door to the conversation that allowed policy to be established through the Office of General Counsel, and that this wording is what they needed to be able to keep those records private. So lots of things to consider, lots of useful conversations to be had. And again, as a student, if I presented and someone wasn't able to guarantee my privacy about my exam, or really even be able to explain the limitations of privacy, then I don't know what I would do, and I'd be concerned and I'd have lots of questions. So there's a lot to be said about trust and respect in this regard. Next slide. Now, moving on, we're going to talk about documentation. Documentation is an important part of the medical forensic exam or any care of a patient who has experienced violence, any care in general. We as providers always document our charting. The problem is trying to decide what kind of documentation, electronic, paper, there's lots of things that we need to discuss. So where is it stored? Who has access? This ties into the privacy and confidentiality aspect we talked about. Also, we have questions such as, when can these records be released and accessed, and by whom? Do you need written authorization by a patient prior to release? This is something that we need to understand. Where does this fall within FERPA and HIPAA? When completing documentation, we want to make sure we have the opportunity for the correct areas of documentation in order to ensure that all pertinent data is gathered as well for objectivity and accuracy. Now, documentation is imperative. In nursing, you hear the phrase, if you don't document, you didn't do it. And there's something to be said about that. But also, on the other hand, and if we need to recall a few days later what medication the patient received that visit, we need to be able to access that, say for like example, if patient was having an allergic reaction. So we need to be able to document things appropriately. Or if we were going to court, we need to be able to speak to what the patient said, the injury we found, or the care we provided. And we need to be able to do this thoroughly and accurately. So documentation is an important foundational concept to this type of care. And the questions that surround it are just as important. So reaching out to your other departments like we discussed, IT, legal, your boards, to figure out what is in the best interest of your institution and your students. Next slide. A multidisciplinary team has a responsibility to work together to provide necessary resources within a collaborative response to sexual assault. For example, the one in my community comes together monthly to review cases that have gone through the judicial process. They review and they learn from each other to understand how we can strengthen our response in the future. What services can we all offer? What education can we provide to other stakeholders, and more? This is a good time to also strengthen the relationships within your community. Either partner with local SART or community coordinated community response, like different names for MDTs, or you can establish your own within the college and university community. Now, our questions are, who needs to be involved? What about local law enforcement, student groups, hospital administration and leadership, mental health and advocacy? Basically, anyone who has a stake in how we address sexual assault on our campus. We want to do a gap analysis and understand where are we lacking in that response, or where local communities are doing well. And we see how we can change or implement those processes. A multidisciplinary team is an excellent opportunity to provide or receive training and education from these other entities and create a form of trust between the different groups. Part of that education is understanding jurisdictional considerations, which can be hard on a campus as there might be local law enforcement agency or college law enforcement. Now, one of the goals is to ensure offender accountability, where we work towards a better outcome, not only for the patient, but also for our communities. So understanding what we did wrong in that encounter with the victim and how can we move to a better response or reflect on what we did good and continue to ensure that quality assurance project within the team. When looking at starting a multidisciplinary team, we want to make sure it is reflective of our actual community. So what does our community look like? For each community, that might be different. And it's definitely our responsibility to make sure that we do not alienate any of those voices that would need to be heard in order to facilitate improved outcomes. Now, we talked earlier about that patient-centered and trauma-informed approach, which is not just kept to the SANE, but needs to be exemplified within all entities of their response. And again, this is a perfect platform to provide that education for other stakeholders and to ensure accountability with respect, and that we're all approaching the situation with that trauma-informed eye. This will also foster a good level of collaboration between all these agencies. When everyone comes together for the same goal and for the right reasons, we can see change for the better. Multidisciplinary teams are important in every community, and I've seen great outcomes when we push and make it worthwhile, an experience to strengthen our response against sexual assault. Other good suggestions for MDTs are tribal leaders and elders, Title IX reps, resident advisors, health centers, therapists, counselors, community-based advocates, local crime lab students, basically anyone who's able to come together with that coordinated response, like we said, to make sure the process is better and better every single time. Next slide. When discussing reporting options, we know that there will be those who are under 18 years old on our campus, along with those who are 18 and older. I also know that reporting options for elders might be different ages. For example, in Colorado, it's 70 and older. So that is why I did not define it specifically on the slide. But I typically find that minors fall under 18. So we're just going to kind of talk about it in that way. And with that, we know that mandatory reporting falls under that specific age for what a minor constitutes and for what an elder is. There are also times when mandatory reporting is when there is a loss of consciousness due to strangulation or assault with a deadly weapon, or children are present. There's these small nuances that are necessary to be aware of when a patient presents. Also be able to navigate how to discuss that with a patient. Because if a patient presents in good faith, thinking that they can receive medical treatment, and then you find out they're 17 and that's a mandatory report, we need to be able to manage those expectations and talk about what we have to offer. And also we just overall need to know what the law says and what we have as far as our responsibility. So on the other side, I have seen firsthand what happens when a sexual assault is reported without consulting the patient about their options. And it didn't have to be reported. Such as in Colorado, we have the options to allow the patient to not report to law enforcement if there aren't any of those mandatory reporting options. However, with some patients, we understand the differences of how to explain these. In some patients, it's just difficult to kind of understand what happened, but their friends and families and stakeholders might also want to know the difference as well. We need to be able to see how we can approach that situation and discuss this with them. Because I see a lot of times also where a stranger assault is pushed really hard for reporting, and that's not always the best interest of the patient for many reasons. Sometimes they might not want to report. And we have to stand by the patient's right to not report, because we know that the world does not rest on their shoulders. Overall, there's a lot that needs to be said about how to approach these situations. And sometimes a sexual assault nurse examiner is well equipped in those scenarios. Now, when we talk about local law enforcement versus campus law enforcement, this of course is just not my expertise, as I'm not in law enforcement, but it's still something that can affect my duties and the way I might approach my response. So it's important to have a discussion. And as knowledge for the provider to be able to articulate to the patient or the family members or friends, whoever we need to fill in. Having local law enforcement and campus law enforcement at the table when making some of these decisions, like we've talked about before, a lot of the policies or, access will kind of also help establish trust. It'll open communication and understanding, and I'll kind of just bring a lot of light from both sides. I've seen how great collaboration makes great strides in the community, and I have also seen how alienation and misunderstanding only leads to difficulties on all sides. Law enforcement can definitely be a powerful part of the response, and they need to be. So also consider your military, tribal, and federal, because those are things you definitely will encounter as well. Following these different jurisdictions is important because they might have different ways of reporting, ways to hand off evidence, or different laws. So we need to make sure we are cognizant of all things that are present in our local communities. Next slide. So according to a presentation done by Susan Rotolo and Lisa Gorham for the Safe TA presentation on the International Association's website, they did a presentation on SANE peer review. They stated, SANE peer review is the review of the sexual assault report by an expert in the field of sexual assault that would include review of the written and photo documentation. As a forensic nurse, we know that this is a unique field, and so much of our documentation can be very closely scrutinized. It is in the best interest of any program to review through the peer review process. So in some programs, it's one designated person, such as a director or manager, who reviews, as they might not have enough experienced people on the team to review. And in some jurisdictions, a review by a medical director or supervisor is required. In other programs, where there is a little more time and resource, everyone on the team reviews charts, making sure that each patient has been reviewed by at least somebody. Or a chart can be reviewed through the staff meeting when everyone's present. Now, this allows for ensuring high quality care, making sure that nothing was missed in following policies, guidelines, laws, and more. Sometimes it's hard to remember everything or make a tough decision in the middle of the night. And it's always good to just have a reminder and have someone looking over your shoulder when you can. Sometimes things are missed, like a time or a finished sentence. As our documentation can be extremely thorough, it might take a while to chart, leaving room for possibly missing something. So reviewing a chart makes it possible to fix some of those things in a quick manner or be able to change practice to include this next time. Consistency is important as well. If we find that someone on the team is offering one type of care while someone is offering another, we can address it and possibly review for quality improvement process if this is something that needs to maybe be changed or updated in the program that we didn't really know about. This also provides a continued learning approach from the new forensic nurse all the way to experience. I find myself sometimes learning a new way to chart something every single time I review a chart, or a different way to present something. But overall, for new nurses, it's a good way to see how they're viewing a chart and reviewing it as well. This helps keep a high standard of practice for the team and for the nurse, and should be a standard of practice in itself. If your program only has one or two forensic nurses without the capability or experience to review, there are other programs or experts out there who offer the service to help review charts as well. Next slide. As violence is a public health issue, I'm a huge supporter of not just addressing the problem in the moment, but providing prevention and education. Now, if there was a nurse or provider on staff, it would be a perfect opportunity to even get the options for reporting out there, like putting out fact sheets or putting out posters to understand what your reporting options are, or where to go when the sexual assault occurs. So maybe a good way in bathrooms to say, hey, this is where you go if an assault occurs. Also, a great opportunity to discuss what happens during the exam. A lot of people don't want to come in because they don't necessarily know what to expect. Fear of the unknown is a big thing. And for us to maybe talk about that at the beginning of every school year or at certain student rallies, that'd be important and something that could possibly ease that fear and help patients understand what to expect. We can also do awareness campaigns. So Domestic Violence Awareness Month, Sexual Assault Awareness Month. These are big things and big pushes, and those are perfect setups for forensic nurses to kind of get in there and get specific education out to students. We can do fact sheets that, like I said, we can put up in bathrooms and more. There are endless amount of opportunities for this aspect that we don't always have the time and resources for, just as a single forensic nurse or as a small forensic nursing program. But it's such an integral part of the response to sexual assault, along with all other forms of violence like we talked about. So this is something that I would love to see sexual assault nurses being able to have more time for the daily roles, but allowing this to be an expectation within your program with the time, with the resources, with the expectation that I'm here to help you set up those parts of the program, then this would be a great opportunity for the campus. Again, the slide in itself could be an entire presentation, but it's a huge part of the plan and can be incorporated into the multidisciplinary meetings. So in education provided to patients and students as a whole. Us as forensic nurses are in a unique position to understand healthcare and their response to sexual assault as far as a healthcare approach. So even just coming and wanting to address the sexual assault, we can also talk about sex education in general. We can talk about safety in relationships. We can talk about so much more than just the one event that they're there for. And that's part of our role, to understand what we need to address. And this is a perfect opportunity for us to start that prevention and that conversation. Next slide. Finally, you can never discount the support from leadership, student groups, and key service providers such as campus law enforcement, campus advocacy programs. Now, these key groups can help make a great team or program work. So fighting for the right equipment, fighting for the right staff or the right number of staff, and the continue to support those who report a sexual assault. Yet, we must also acknowledge past trust issues with leadership or law enforcement or medical staff and build new trust. Jen Markowitz mentioned in her presentation that she suggested establishing a SANE community advisory board, meeting monthly or every other month or quarterly to discuss options and voice concerns. This is very, very important to be heard. What's needed in your community might not always be what is needed in someone else's, and vice versa. This takes a lot of planning and consideration, but there are resources and people out there to help. This is such an important thing to address that I appreciate each and every one of you taking interest in this webinar and in the response to sexual assault on campus. Now, just like the multidisciplinary team, this advisory board needs to be made up of those who reflect the local community and those we service. If we have a high tribal community, high population of tribal community members, but we do not have anyone in the tribal community on our board, that's a significant problem and a missed opportunity. There are other things that need to be discussed in more detail, such as supplies and equipment and payment for exams. These are such specific concerns that they're harder to address, like in this webinar specifically. But if you do have questions about these, I'm happy to facilitate a discussion or put you in touch with someone who can have that conversation with you. Now, this is not, of course, the end all be all for how to start a SANE program or how do you partner with the SANE program, but it kind of puts things into perspective of a good start and a good understanding of what's needed, what's expected, and what you can look forward to in doing this process. Next slide. I talked about partnering with the local SANE program, and here's how. So as of October 2021, there were 999 SANE programs registered within the International Association of Forensic Nursing. This was on their International Association of Forensic Nursing program listing. So these programs could be child advocacy centers, family advocacy centers, hospital or medical centers, but these could be options for connections, resources, or even MOUs for treatment. So partnering with local programs can be great options. And we do that, I know, with a lot of our local community members and organizations too. So it's just a good understanding that if something happens, we know where we're sending you to, or we know how to receive help if something happened. Next slide. This is how you would access that program listing on the International Association of Forensic Nursing site. So you would go to the IFN site, you would go to Resources tab up at the top, go to the Forensic Nursing Program listing, and then find the Forensic Nursing Program. So once you do that, you can, if you kind of see to the left, you can see the country, location, program name. So you can search that way. Next slide. Or you can reach out to me. My name is Tammy Scarlet. My email is tscar lett@forensicnurses.org. My phone number is 410-626-7805, extension 128. Does anybody have any questions? Anything else we can talk about? Well, I really appreciate everyone listening. Thank you so much. This is a big process and a big undertaking sometimes, and it's not something that you should have to handle on your own or have to understand on your own. So reach out to us, reach out to someone within your local community like Advocacy or another forensic nurse in your program. Overall, I wish you all the best of luck. And if you have any further questions, please don't hesitate to reach out to me.
Hey, Tammy. Here's a few more different things that were references throughout the presentation. If you haven't caught all of these, don't worry. This was recorded and it will be up on our YouTube. So you can watch all this again if you need to. We will also be sending out the PowerPoint if you would like. So if you have any questions, you have Tammy's email and you have my own. And does not look like we have any questions. But before we end the session, I want to let you all know that there will be an eval popping up once Zoom closes. We'd love to hear what you thought. So if you're able to fill that out, we'd very much appreciate it. We'll be sending out a newsletter when we have our next webinar or set of webinars approved. And as a reminder, once again, this webinar was recorded and will be uploaded onto Redwind's YouTube channel within the next few days. You can also find previous recordings there. So if there's any other things that interest you with Tribal College Campus or any of our other programs, you can find more trainings there. In closing, I'd like to thank our presenter, Tammy. I'd like to thank our captioner, and I'd like to thank all of you who joined us. I hope you all have a wonderful rest of your day. I hope you all stay safe, and I hope to see you all at the next webinar.